Well, hello, everybody, and welcome back. I am a very ridiculously excited mommy today because we're kicking off the new season of the podcast. Erin and I are, and this is the first episode of the new season, but also on Saturday, we're picking up a new rescue dog. And I mean, y'all have been with us since the beginning. You've heard Chewbacca and Miss Dogwood, aka Dog, their trials and tribulations, and Pack Dawson has not had a fuzzy four-legged puppers since Dog passed in December, and it's been really, really hard. But on Saturday, we are getting Miss Waffles Adelaide Puppykins Dawson, aka Waffles, and she's a rescued Carolina dog. And my heart is so full. So, Miss Sean, Miss Kay, if y'all ever tune into a podcast, thank you so much for helping us find our rescue puppy and getting her home to us. But okay, moving on. Y'all, we have a very, very busy season planned. The episode that you're about to listen to, honestly, this episode has been 2 to 3 years in the making. So let me give you a little bit of the backstory. For the last 2 years, I served as the Pediatric Feeding and Swallowing Disorders topic chair for ASHA for the annual convention. This year, to my knowledge, it's Dr. Memory Goza as well as Juliet Ochura. Memory's from Alabama and Juliet's from Boston Children's. They're co-chairing it this time around. But the last 2 years, I was doing it solo, which is for the birds. I'm so glad that they've decided to do a co-chair. But as part of the committee that I created, we put emphasis on creating a invited topic that covered DEIA and barriers within the framework of pediatric feeding and swallowing disorders. Some of the speakers served as invited speakers in that topic for the last 2 years. Some of them just stepped into that role this past November. But this has been a passion project for a lot of reasons. Getting into the world of pediatric feeding and swallowing disorders as like your specific scope of practice is incredibly challenging. One, from an academic perspective, there's not very many graduate programs that have a standalone course for pediatric feeding and swallowing disorders. Two, there's even fewer graduate programs that treat pediatric feeding and swallowing disorders in their university clinics. Shout out, though, to Jennifer Eagers, and she just led a $25,000 grant or she was just awarded that to set up a PFD clinic at Marquette University. So, oh my gosh, congratulations, ma'am. But that is like such an anomaly. There's so few PFD clinics, and it creates like this funnel effect, right? We have all of these graduate students that want to enter into this specific area of scope of practice, but they may not have academic coursework training. They may not have on-campus clinical training. And then even getting into a practicum site that in an off-campus setting that treats it is incredibly competitive, especially if you want to do something intense like NICU or PICU. It's one barrier after another barrier. And then add on to that, there is still systemic racism that acts as a barrier for our BIPOC future colleagues to even get into graduate school. I can tell you firsthand, I witnessed racist attempts at racism to prohibit students entering into clinical practicum sites back when I lived in South Carolina. Luckily, we were able to overcome and power through, but I've seen that, right? This is something that is alive and breathing in our country and should not hold a place there, because the little ones that we serve, they don't they don't look like me. They come from all of these beautiful, colorful fabrics of life. And that's what makes our nation great to me. This past week is Memorial Day. And in truth, Memorial Day tends to be a somber celebration for Peck Dawson. My husband was a West Point grad, and the reality of what today stands for is something that we need to talk about and honor. But those that gave their all for all of us. And all of us look different, act different, have different faiths, and so do the patients that we serve. So it seemed kind of fitting to tie in the new season with a talk on DEIA, as well as having it dovetail into Memorial Day, so that we can connect the symbolism, the importance, the value, and choose joy and kindness and create opportunities to make our specific profession better. So that's a lot. That's a heavy start, but I'm just so freaking excited about the dog, about the podcast. Like, life is good. So thank you for joining us. Thank you for everybody that has served, has a loved one serving, that has paid the ultimate sacrifice, or their loved one or their forefather or foremother has. Thank you. I hope that you enjoy this episode. Don't fret. In next week's introduction, I'll introduce Waffles, and I'm just hoping she doesn't have fleas, because she is literally a rescue and she's riding in my lap all the way back from South Carolina. So we shall see how that turns out. But y'all have a beautiful week, and thank you for joining us. And I will talk with you soon. All right, everybody, we are kicking off a brand new season. And I'll be honest, I have fretted over how do we start a whole new season with joy and positivity and putting emphasis on healing for the patients that we've been called to serve, when in my gut, I feel like I'm watching my world burn around me, when I'm watching my colleagues fall under attack because they and we and I stand up for DEIA, for you pick your pronoun, and my version of Jesus loves everybody. And so with all things, I put a lot of prayer on it. And these lovely women that are on today have a spirit of yes. And it seems fitting that we kick off a brand new season in honor of Pediatric Feeding Disorder Awareness and ARFID Awareness Month, with a crucial conversation on DEIA and its role within the framework of PFD. So, to be perfectly clear and to not mince words, diversity has a place in our profession and in those that we are called to serve. I am intimately aware that because of how I look, because of the color of my skin, I have privilege. And I don't think I realized the immensity of that 5 or even 10 years ago, had it not been for Dr. Frances Burns, Dr. Michelle Norman, for these women pouring into me and growing in me a passion to stand up and to open doors. If it hadn't been for sweet little Myrnie Mern, who mentored the daylights out of me back in Columbia, South Carolina, on LGBTQIA+, on chest feeding versus breastfeeding, on all of these different factors, how small would my world have been had it not been for the grace that I have been shown and given. So, with a very full heart, welcome back to First Bite for a brand new season. May this fill your proverbial cup. May you have a literal cup. This one is echinacea support tea because, like always, Pac Dawson has cooties running through it. And we're going to kick off with our guest. So because we have a very full panel, I'm going to give everybody a chance to introduce themselves, why they became a speech therapist, where they work, and what they're hoping that our time together today pours into you. So, Lindsay, because you're in the top left, love, you're up.
Awesome. Well, my name is Dr. Lindsay Turner. I've been a speech pathologist for about 14 years now. I started off my journey in Baton Rouge, Louisiana, working in an outpatient setting. And I kind of trickled into PFD through a NICU journey. So I noticed that a lot of my outpatient kiddos were coming in with a NICU history. And I just really wanted to see what that environment looked like what made that patient different from a well baby that went home after a couple of days in the hospital with mom. And they usually say, once you go NICU, you never go back. And that's exactly what happened to me. I fell in love with babies, and as I gained more experience and more confidence, it went from loving just the PO feeders to then working with our tiny babies, our 23 and 24 weekers, and figuring out what my role was with helping those babies and their families. Through that journey, I became an IBCLC. I became a certified neonatal therapist, a neonatal touch and massage therapist, and I opened up a private practice as well. So, and I also teach at a couple of universities. So I am extremely passionate about babies, families, interdisciplinary collaboration, education, just that's me. And I'm very passionate about the topic that we're going to be speaking on today, being a Black woman in this field, and also being a Black SLP working in such a niche area as NICU. It has been a very interesting journey for myself. And I'm just really excited to talk to you about it today with these wonderful ladies.
Who wants to go next? I'm like, well,
I can go. I'm Leena Sayed. I'm a current SLP graduate student at James Madison University in Virginia. Expected to graduate in just a few weeks, so I'm counting down the days. Awesome. And fun fact, I first met Michelle in my first semester at JMU, where she was my clinical supervisor for my first pediatric feeding patient. And that is where I fell in love with pediatric feeding and communication and working at the intersect of feeding and communication with this kiddo who had an AAC device. So I'm not a speech therapist yet, but I fell in love with this field and fell in love with pediatric feeding. As growing up, I've loved working with kids with disabilities. I loved supporting their growth and development. And when learning that speech pathologists can work in medical fields and kind of tackle those issues as well, I found pediatric feeding, and I'm excited to learn more about what the field has to offer. I'm also very passionate about advocacy for marginalized individuals. In undergrad, I had the privilege of serving on the board of an organization that supported minority students in speech language pathology and audiology. There, I also spearheaded efforts in expanding American Sign Language at JMU. And from that, we expanded the course load and hired the first deaf professor to teach ASL at JMU. So all that to say, I love learning. I think spreading knowledge and learning more continuously in our profession is the most important thing we can do. So I'm excited to talk with you all today.
I can go next. Hello, everyone. I am Dr. Megan Richmond. I have a lot of years of experience in the field of speech pathology and feeding. So I actually started my journey with pediatric feeding disorders at Mount Washington Pediatric Hospital in Baltimore, Maryland. One of the unique features about that hospital is that it offered a day feeding program. And it's one of the first places that I had an opportunity to see this interdisciplinary model and approach toward pediatric feeding, where occupational therapists, speech pathologists, psychologists, developmental pediatricians, and also dietitian worked together every single day to come up with these very unique treatment plans for the family. Yes, we admitted patients, but the treatment plan was focused on the family and how you move from this intensive treatment program back to the community. So that really kind of was the beginning of my passion for working with individuals with pediatric feeding disorders. I spent a lot of time at Spartanburg Regional Healthcare System in Spartanburg, South Carolina, working in both the NICU outpatient and also PICU, once again with families and also with children. But in that setting as well, during my time there, my position was kind of threatened due to some legislative changes. And that's okay. We learn from all experiences, but I wanted to learn more about how the legislative process and just health policy impacted our role as clinicians. So I pursued a doctorate in healthcare administration, and I've really been engrossed in health policy, health economics, really leaning into advocating for our profession, for our families, for our patients, and then also working on various committees on a national level as well to try to impact how we can increase accessibility, affordability, and then also those quality health outcomes for children with pediatric feeding disorders. So I'm excited to be here talking with everyone this afternoon too.
I'll go next. My name's Inéz Esparza. I am a speech language pathologist at Ochsner LSU Health in North Louisiana. I always say I didn't choose the SLP life, it chose me. I have an undergraduate degree in business administration with an emphasis in healthcare administration, but I quickly learned that the back end of healthcare was not enough for me. And along that journey through interpreting, I found speech language pathology. And now I realize that I literally switched my career to diversify the field because I saw a need. So I was a speech language pathology assistant working in early intervention, and that led me to learning and exploring pediatric feeding disorders. And as I finished up SLP grad school, I found that pediatric feeding disorders were the things that kept me up at night. I switched from reading books for fun to reading research, and I still do that. And so that's how I know I really, really love what I do. I currently am the only pediatric therapist in our crew, so I cover the NICU, the PICU, and our floor patients for our hospital. And I get lots of help when needed from my colleague, Meredith. And with that, I'll push it over to her.
Hi, everybody. My name is Meredith McLain. I work at Ochsner, like Inéz said, with her. I have been an SLP for 14 years, going on close to 15 in August. And my journey with pediatric feeding disorders is very mismatched. So early in my career, I worked in outpatient, and it was a hospital-based outpatient clinic. So we saw everything. I went from a stroke patient at 8 to a pediatric feeding patient at 9. And it was very complicated. There was always changes. And so that's kind of where I got started with more pediatric feeding, because being hospital-based, those were typically the referrals that we were getting. I then ended up moving out to West Texas, and being from East Texas, it's considered fairly rural. And then I really learned what rural meant when we moved out to West Texas. And I ended up working for Medical Center Hospital out there, and there was a huge need for NICU therapists. They didn't have a speech pathologist or really even occupational therapy or physical therapy in the NICU for quite some time. Before I got there, there had been people who had come through and rotated, but it was basically an area of need where nobody else that was there really felt comfortable. I'd had, some experience in the outpatient setting. And so I kind of dove in and learned as much as I could, as fast as I could, and went into the NICU there. I worked in the NICU there for about a year and a half. And then we were able to hire another amazing speech pathologist, PRN, who worked solely in the NICU, who had just an excellent personality. And so she kind of took over that space, and I just helped support her when she needed. And so, which I absolutely loved. It was a perfect fit. And then I ended up moving closer to home back here over to Shreveport. So that's where I'm at now. And I have just basically here been the person that has helped support the whoever the pediatric therapist was, because I'm the next person that is comfortable and has, the experience and things like that. So it's really awesome because I get to learn a lot from Inéz now. So she teaches me a lot, and she keeps me up to date with all the reading that she does. She forwards it on to me. So it's kind of nice because she does all the heavy lifting, and then I just get to benefit from it.
Awesome. But it takes a team. Everybody here is because you've been part of a village. You've had mentors pour into you, and then you turn around and, you become the teacher. So, yes. Okay, well, ladies, thank you for joining us. And to put it very direct, very, very direct, we are all aware that DEIA is under attack. It's at all levels of our training and service delivery and access to care. So can y'all kind of walk us through how detrimental this is to our field and specifically our specialty area for the little ones that we serve?
One thing that I will chime in on when I think about, diversity, equity, inclusion, and accessibility, and how detrimental any of our current, policy changes or legislative changes are right now, is when we think about what our goal is as professionals. Many of us are working collaboratively with families and with other professionals to be able to just ensure that people who have communication or feeding disorders are able to function to their highest ability within their community, within their schools. And hopefully, of course, we are preparing a lot of our children to move on, of course, into whatever their desired profession or vocation is. And so when we think about taking away any of the various levels of support that are available for this population, it hinders what our ultimate goals are as a profession, to help individuals be able to, eat at a lunch table with their friends, to help families understand how to navigate, the healthcare system for the best outcomes for their children, to be able to access, resources throughout the healthcare system as well. I feel like as we adjust any programs, any allocated resources, even when we think about, the fact that research shows that a lot of families do actually want to work with professionals that look like them. And when we cannot diversify our actual profession for a variety of reasons, it impacts patient outcomes. And it moves us away from the goal to be efficient providers that are trying to move toward how do we make this person function at their maximum capability within an amount of time based off of what the family or their community desires. So it's really kind of going against what any of our goals or objectives are on each level.
I'd also like to chime in on that. when, Megan brought in having a service provider, a clinician who looks like the patient, when Inéz and I did the first talk a couple of years ago at ASHA, that was one of the things that we talked about. We talked about different levels. We talked about the academic programs, as well as having clinical practicum experiences. And we talked about cultural competence and cultural humility. And, one of the fears that I have right now with DEIA being under attack, it's a couple of things. First of all, that people outside of our field, when you hear DEI or DEIA, there are always these assumptions that it's just about differences in ethnicity. But it's so many levels, and there are so many marginalized, minoritized children and adults in this country that aren't being considered when these changes are being made. So you have our patient population, you have their families who are being affected, as well as our academic programs. And when we want to maximize the diversity within the academic halls, and outside of that, we also have limited exposure to PFD in graduate school as it is. So now you're whittling things down to a minority specialty area, and now minoritized individuals who are going to be impacted by this, who want to work with children who have feeding disorders. So that's kind of been my soapbox as a professor. Like, how is this going to impact the students that we can receive into our halls? And when I speak to these students, when I'm educating them, am I limited in what I can converse with them about, and expanding their viewpoints on the cultural aspects of what we are facing out there in the field, as well as what we deal with in the workplace? Okay, so when you are a minority and you are working, like in my situation, I'm one of the only Black women who work in my unit. And there are times where I feel, I'm expected to either behave a certain way or go and have a conversation with another Black family because we look alike. Those are things that I have to consider, that our future SLPs need to consider. And we shouldn't be watering anything down. We shouldn't be taking that away from our academic programs, because ultimately it's going to trickle down and benefit our clientele.
Yes. So a couple folks, if you're not familiar with the intricacies of academia, just to kind of start there with how this impacts the future of our profession. With the new administration coming in, most academic programs had to scrub any DEIA language from their websites because of threats to funding, threats to research grants, threats to especially state-funded schools. So over the course of the last year, I've seen academic programs either change their wording away from DEIA or alternate out the language so that it doesn't pop up in any search engines or search bars. And then we get into the piece of the government withholding funds. This directly inhibits new faculty hires. I know several of the programs here in Virginia have actually put a complete freeze on all new hires because they just aren't sure where the funding is. And this directly impacts our niche areas, because to go where the research tells us, this past November at ASHA 2024, Dr. Memory Goza, Dr. Aaron Kleinert, and there's a third whose name has just eclipsed my mind. They did research on the level of PFD being taught at graduate programs, and then the PFD clinical experiences for the students. It is so scant. And most of the people that are teaching those courses are honestly, PFD is very rarely a standalone class. It's embedded within adult dysphagia. So it's already disproportionately not funded. And then because of all of these concerns, it will be less funded. And the funding and the research that has historically been done in the world of PFD takes place with upper middle class white families, i.e. professor children from the Northeast. Very rarely is the research base actually, does it mirror those that we serve? And I say yet, right? Because there is some that is coming. So to give hope, I would recommend Dr. Amy Delaney out of Peds Feeding Marquette. She's got some updated research that's getting published this year. She had a delay in delivery because she overcame breast cancer. Go, Amy. And that will be coming out. And Dr. Marcia Duncline, who Get Permission Institute. She's actually been researching autistic adults and their experience with feeding. And she's the only researcher that I am aware of, if y'all know somebody different, tell me, that's interviewing neurodivergent individuals as like research, like tell me about your experience, let us grow from. So there's that all trickles down, but I have to put the plug in here. And then Megan, I'm going to volley to you. There is a reason ASHA is not perfect. Your state associations are not perfect. I am intimately freaking aware that your state associations are not perfect, having served as president of one association and now being a vice president of speech pathology for another. But what I can tell you is that in these volunteer capacities, we are busting our butts to improve access to care, to improve funding, and it is all volunteer work, right? Like, no, we're not getting paid for this. We're there because we need to do better. But it is your membership in your state association that those funds then pay for the lobbyists, because ASHA advocates federally, but it's your state association level that advocates for your Medicaid reimbursement being equitable across state. It advocates for scope of practice encroachment when you have, I don't know, ABA therapists or music therapists that wake up one day and decide they want to do feeding therapy, which is outside of their scope of practice in both accounts. So that's a soapbox for another day. But it is each one of us doing the work, right? So Megan, I know you're heavily involved in that policy.
Yes. And Michelle, what you're saying is very true. It is purely voluntary. There are clinicians from across the United States. And I think one of the most profound stories that I heard was about, there's a clinician in Oregon who has a private practice. And so she actively engages on behalf of ASHA to go to Capitol Hill, to meet with legislators like from her state and also other states to advocate for increased access, making sure we're reducing like the Medicare cuts. She talked about the numbers in regards to how much she loses when she's away from her clinic to go and do advocacy work. And it is almost astronomical. Like, I don't want to misquote, but I mean, when I heard it, I thought to myself, like, whoa, that, think about if she has to pay like someone's salary for a week or 2 weeks. It was an extremely large number that her accountant, she said her accountant kind of asked her, like, wait, what are you doing again? Why are you out of the office for, 3 days to go and talk to legislators or to talk about coding and billing and to collaborate with ASHA and to bring that perspective? That's the beautiful thing, is that as clinicians, we can be actively engaged with bringing that perspective to the table firsthand. Like, this is what we're experiencing in our clinic. This is what we're experiencing in our state. This is a story that happened with, my patient, how they got denied and how, the insurance company gave me the runaround about reimbursement. All of those stories get told and they're very, very firsthand. So yes, We, as you know, state organizations and also ASHA on a national level, we have these phenomenal lobbyists, our health policy analysts that work with us. But also what they do is they say, walk beside us, like partner with us when we go and talk to these legislators, and we can talk about, you know, the history of a bill and what it may mean, or how we need to sway this legislator to think about this from a perspective for better outcomes for our patients. But we're there beside them to be able to say, this is our experience, this is our story, this is how I can leverage my patients' voices through advocacy. So it requires a lot of time. There are people, like I said, on the clinician level that are sacrificing time with family. They're sacrificing time off from work. Like they're using their vacation time from work sometime to go and do policy and advocacy as well. But they do it because they are passionate about what we know that what we can achieve collaboratively. When we do work together, when we are consistent in our efforts, when we are consistent in our language, then we know that there can be positive outcomes. We have seen them over time, but I think we all have to really lean in and be very open to
Inéz,
that
you
as
and I
well.
met 4 years ago, 5 years ago, a minute ago.
Yes, it's been a while.
It's like, and you have gone on to volunteer in such a rich and robust capacity. I know you are helping with Feeding Matters to translate some of the documents into Spanish. You're serving on the Hispanic caucus. Like you have walked this walk, but the intimacy with which you have served families as a bilingual therapist and as a translator, what does this mean to you? Like, what is the impact there?
I think that the attack, let's call it what it is, the attack of DEIA stems from a place of ignorance about the uneducated and the educated. I think a lot of us, like bouncing off of what Megan said, we know so much, we know the impact, and it's not just because we see it, it's because we read about it. We go down and dirty into the research and we see the numbers and the outcomes. And at least for me, that's where the passion comes from, because one, I saw it, I lived it. I am DEIA. I'm the product of everything good that has come from it. And I multiplied like all the benefits, and I pass it along to, incoming students and the families that I serve. And that's why I'm going to keep fighting for it. I'm going to do you want to listen? Or you know what, you're going to hear me anyway, even if you don't want to, because I know it's right. And I think that's where the passion stems from. To me, it's not about being right or wrong. It's about, I'm just going to show you. I know you don't believe it, but here it is. And I've been successful with, some colleagues, or at the very least, I get them thinking. It's not black and white. And I enter those spaces where I think I'm most beneficial, which is through volunteering, which is a lot of work, but I think, yeah, that's why I was clapping when you were talking about the state association. I'm the STAR rep, which deals directly with Medicaid reimbursement.
Wait, hold on. Let me, folks. So each state association has 3 liaisons directly with ASHA: the STAR, the STAMP, and is it the SMAC?
SEAL.
SEAL. SMAC. SEAL. Yes. STAR represents Medicaid reimbursement policy for your state association with ASHA. STAMP does Medicare reimbursement with state association and ASHA. And then the SEAL is the school liaison, if I got that right, with ASHA. And it's a critical channel, because that means she attends like monthly meetings and has direct communication. between national and state level issues so that we can advocate at the state, hey, these are the problems that we're facing. And it gives you your state a sounding board. I don't know, I can't legally name insurance companies, but there was insurance companies in Georgia that were making very poor patient choices. They tried to move into South Carolina, and then our South Carolina peeps were like, they raised issues with HHS, and then they were not allowed to expand contracts into South Carolina. So again, this is volunteer work. Also, I have no idea how you do this around your daughter's softball schedule. So
So all of that and everything that's involved, it's all the stuff that is in the background for most people, even within the field. For most, they go do a job and go home, and that's okay. There's nothing wrong with that. But then when I'm losing my mind talking about how unfair it is, how problematic something that's coming is, and how, detrimental it's going to be for our patients, I get the looks. I get the, she's crazy, you're an alarmist. No, it's because I've probably seen it before, and I've seen the process, and I know the impact. It's not just because I'm crazy.
yeah. So I want to get to the hope, but let's finish going through like how this is impacting us all. I'd like to switch to Leena real quick, because Leena, you inspired me with your work. So backstory, I'm a firm believer that women should have access to toiletries, and it should be free, right? Like the fact that like I had to pay, well, I don't have to pay for tampons anymore because a hysterectomy is God's gift to me. But prior to that, tampons get expensive. And when you're a grad student, paying for that is expensive. So I would stock up our floor of JMU with like tampons and those kind of things. And Leena came to me and mentioned that different faiths don't use tampons and they also need pads. And that was something that I didn't know about. I knew enough to get the unscented versus like the scented, because Duditas and research now we shouldn't be using scented products, but Duditas is what we call it for my children because I'm unprepared to talk to that with the 10-year-old yet. But Leena started the conversation, and that led to other conversations about high holy days and how holy days were celebrated within the different faiths. And that led to conversations about food customs around holy days. And that is something that, and I have said this for years, and I will see this through to fruition. I want to see an SLP or clinician of faith caucus for ASHA to have these resources. But I know my faith and those high holy days. I don't know about others. So Leena, can you talk us through? I started with the pad talk. There you go. You're welcome.
Thanks for bringing this up, Michelle. I think it's such an important topic when it comes to pediatric feeding, but also any healthcare professional. When we're working with people come with different backgrounds, different experiences, and even if one patient comes from a certain religious background, doesn't mean they're going to be the same as the other person of the same religious background. So I think one point when it comes to thinking about DEI and working with people is you're never going to meet the same person with the same traditions. And we're never going to have all the knowledge of these cultural and religious nuances of the person in front of us. And we are not expected to, regardless of the clinician's background. So really approaching these patient interactions or professional interactions with others as well with an open mind and with no assumptions at all, I feel like is the most proactive, most accepting way to approach these scenarios and to approach DEIA in a clinical scenario. But you asked specifically about religious customs. I think I could go on and on. I'm a Muslim, and I practice that faith. There's so much I could talk about. There's so much we could all talk about with our different religious customs. But I think in terms of our conversation today and kind of going into these clinical scenarios, we really have to go in blind. Even if we may have an assumption about this person's religious background or cultural background, asking questions, being open to learn is the most valuable trait I believe we can have as clinicians. And reflecting on my own clinical practicum experiences, I've had supervisors who were people of color, not people of color. And I think regardless of someone's background, an open-mindedness and the willingness to learn from the patient without any prior assumptions is the most ideal kind of framework to approach cultural competency and religiously informed care.
Yes. I will be honest, when I was in South Carolina, I had never worked with a family that was part of the Muslim faith before. And I was trying to, and y'all do as I say, not as I do, but I was trying to give examples on like the viscosity of the food. And I always have like sample foods in the clinic. So I pulled out a can. I was looking for like a minced and moist consistency, like an Itsy minced and moist. And I pulled out the pork beanie weenies instead of the vegetables, and the kerfuffle that ensued because I had no knowledge, but I also didn't ask. And so, bless, the mom started laughing once we were through it, and then her husband translated for the mom, and it turned into this joyful learning experience. But had there not been open hearts and kindness, that could have been horrible. But y'all, it's as simple as when you do your intake eval, just asking, regardless, don't make assumptions, regardless of what they look like. Do you adhere to any faith? Are there any food customs we should know about? Just asking. Do you pray before meals? I can't tell you how many little ones that we've prayed before since asking that question. And the caregivers are like, thank you. And I'm like, of course, honey. Like we're all learning together. But yeah. Now, Megan, you've kind of been Texas and Louisiana, and you've seen different intensities and settings from rural to city. How does this impact you and yours?
That's a really great question. I think from my perspective, Leena said it best. It's like not making assumptions. I think even though that doesn't sound like a very broad area, Texas and Louisiana, it's a very small part of our country. There's so many different cultures that reside within those two spaces. Even just within Texas, East Texas is different than West Texas, which is different than Central Texas and Southern Texas. And when you deal with people or work with people who come from different backgrounds, a big part of Texas culture is immigration, typically from South America and Mexico. And people will often just think everybody is coming from Mexico and everybody's coming from like one space in Mexico. And that's not true. There is definitely patterns where like typically people from a certain area will move into East Texas, but that's mostly just because you're going to go where you have other family members and other support systems to go. So there are some patterns there, but it's different. So Mexico is huge too. If you have somebody from the West Coast and the East Coast, they use different words for things like nipple. So when you're doing a NICU feedings and things like that. And I have a memory of one time my coworker who was an SLP and bilingual was interpreting for me, and he used the word for nipple that he's used to using. Well, they were from a different part of Mexico, and the word that he used was not the right word. It was referring to the body part, and in a way in which was not appropriate for NICU feeding. And it was pretty humorous because the mom kind of looked at him and he was like, oh, he knew immediately. He's like, you don't use that word. And so that was kind of funny. I think it's just, For me, it's just about learning. Like I sit back and I learn a lot. So I often tell everybody on the panel, I'm not really sure why I'm here. But I love being here, and I'm so glad I've been invited because I've learned so much from everybody from this experience. And I think I really wished more people that come from my background would be willing to do that. Just to sit back and like listen and be a part and be a fly on the wall. And I think you can really learn a lot. And that's what I do with my patients a lot too, is I try to not ask yes and no questions, because parents are able to communicate. You know, we're not working with somebody who can only answer yes and no questions. And so I try to ask open-ended questions and get them to tell me more, because the more they tell me, the more that I understand the situation and can kind of maybe come up with a way that's helpful to them. So
our profession is 93% white female, and that is not the humans that we serve. And so we have to lead it, push it, advocate for it, just like you said, and to be open to having the conversation.
And you don't necessarily have to have a DEIA program, you know, to do those things. I think Meredith said this when we were chatting this weekend, and it makes so much sense. You know, you just have to be open, and you have to be a little bit uncomfortable at times. And, you know, I feel like, and I don't know, Meredith could probably speak to this also, and you as well, Michelle, but having those uncomfortable conversations become more comfortable the more you do them. Does that make sense? And just saying, you know, I don't know everything about this different culture. Let me ask these open-ended questions. Let's, you know, let my follow-up question tag along to that so that they understand that I do want to know more. I do want to know the complete picture behind your family and how I can help you. So you don't have to have legislation necessarily or a curriculum or a program for that. It's more about being a good human, I think, and acknowledging and accepting those differences and knowing that that is going to maximize your potential as a clinician. You know, and we don't take that oath of do no harm like MDs do, but we are still medical and we should be doing no harm. And from this standpoint, from providing maximum care, I don't want to cause harm. I want to give you everything that I can. And part of that is asking those questions and finding out more about you.
Yeah, I just wanted to kind of comment on what you just said. I've never been part of a DEIA program. I've never, you know, even had one at work to be a part of or anything like that. At school, we didn't really talk about it that way. Again, I graduated 14 years ago. It was a different landscape back then. But what I did, which I think is how I ended up where I am right now with you guys, is I took to heart the education that I did get about making sure that I did take into consideration, even though it was just a simple statement of you have to take into consideration if there's any food restrictions, just like you would if there were allergies or something like that. And I think that just because I wanted to do my job the way it was supposed to be done, and I can't fathom a way to do pediatric feeding therapy and interventions without it also being compliant with a DEIA point of view. Like, it's all intertwined so much. There's just no way around it. I mean, if you're going to advocate for, if you're in a school setting, you need to advocate for a student to have a built up spoon or fork so that they are able to feed themselves. If you're not doing that from that perspective, then nobody has to offer them that. Like, there's just so much there that I think so many people take for granted that is there and that we've grown up with. Being a millennial, that I think a lot of people in my age group just kind of take for granted that these resources are just there for people, but it's because other people before us have fought so hard for them. And so, I just wanted to kind of say that.
I also want to kind of chime in on what Lindsay and Meredith said, like significant points when we think about, Lindsay mentioned like, no, we don't take this oath of like do no harm. And then Meredith stated, she used like the word compliance. And so I always I've started trying to, I know it's a mouthful, but I try to say it all out, like diversity, equity, inclusion, accessibility, because I'm like, I'm sure everyone has seen or heard people say, which component do you have a problem with? Like if you have a problem with this acronym, like which one do you have a problem with? And so when I think about what you guys are saying about how our goal is to, of course, do the right thing. Like we want to see people with equitable services. We want, for experiences to lead to like accessibility. And so when it relates to how I shape a pediatric feeding patient's treatment plan, or how I'm communicating with them, I think I kind of mentioned this earlier when we started out talking about this, is how it can lead to inefficient care when we aren't open to learning, when we aren't communicating, when we aren't listening. It leads to inefficient care. Inefficient care leads to prolonged care. So for those therapists that, and we've all heard that therapists that have said, this patient's been on my caseload for a long time. I've tried everything. I want to see if I can transition them to somebody else, or maybe they feel like the parents may, sometimes they're like, oh, the family may not be following through. That's when we sometimes need to sit back, of course, and kind of like reflect and think. And have we asked all the appropriate questions about, what the cultural competence that we need in building the plan of care, so that care isn't long, so that we as clinicians aren't burnt out, so we don't lead to being concerned about compliance and fraud and things like that. So I think when we think about like why we should always be so concerned about how we are going to make sure that we are providing like quality, equitable services, we want to also think about like, how can we move within this space and advocate for making sure that we end up having, like I said, just the most quality outcomes by alleviating that inefficient care.
I also wanted to add, Megan, and we've briefly discussed this before, it's DEIA, just the letters are triggering, especially right now. Call it something else. What do you want to call it? The need for diversity, equity, inclusion, and accessibility specifically to SLP patients and families is there. So do we shift the conversation from the letters to the need? Like it's still, we still need to do this.
Yeah, it's not going anywhere. It's not. And, they can treat DEIA like it's a cuss word and, oh no, it's a horror. No, this is life. This is real. And the 93%, predominantly white field that we work in just really needs that wake up call. There shouldn't be griping and complaining and moaning and being upset if there's a little bit extra of a CEU that we have to do, or, a graduate program, a professor says that these things need to be considered. This is providing the best possible care for equitable outcomes for all of our families, period. And if you don't like it, this probably isn't the field for you. And, we're only talking about this today within the realm of PFD. We could talk about this for hours if we go through the entire scope of what we can do as speech language pathologists across the lifespan, So I think that's that's what bothers me, you know, going along with what Inéz was saying about it being so triggering. I think just having to have the conversation over and over again, and there's still so many individuals who don't bend and understand the relevance of these uncomfortable conversations, that's triggering for me. And I am involved I'm not doing the legislative stuff because, Megan, I can't understand some of the jargon, but I'm trying to manage it with the hands-on in the unit, the hands-on in a patient's house, and in my delivery to my students and to the students who come into my unit. I see so many realms that need the conversation. It continues to disturb me that there are intelligent speech language pathologists, whether they are in the clinical world right now or if they're in the research world or they're professors who don't care to acknowledge the relevance of this conversation. And, you know, you brought up like the timing of our talks and everything. I think, you know, Inéz really had to hear it from me because I wanted to have that talk at a time of the day where, you know, everybody could come, you know. I'm like, no, there's so many people who need to hear this. They're not going to come at 8:00 in the morning, you know, and that I just want to scream it from the rooftops to so many people, like, come and listen to this, join this conversation, be uncomfortable for a few minutes, and then you'll realize, wait, it's really not that bad. We're just trying to be good humans.
Okay. I have 2 pages of notes because I am who I am. Okay. So the first one, let's go with accessibility. So when I'm looking at accessibility for PFD, it's not just accessibility in care. Like, are there enough clinicians to go around? But it is also, when we're talking about DEIA full picture accessibility, it is, do we have fiber optic lines going to rural communities such that if they can't get to a therapist locally, they can zoom in for therapy somewhere else? And no, that is not a thing in a first world nation. Don't get me started about maternity leave. We could just start with fiber optic lines, right? And we know from the significant amount of research that Dr. Jean Marshall and Dr. Madeline Ratz out of Australia have contributed, you can do beautiful pediatric feeding and swallowing therapy over telehealth, and it can be done well if we have accessibility down to even fiber optic lines. And if we truly make it affordable for all, including those with lower socioeconomic status who need access to internet to learn and to grow. Go ahead. Somebody's going to say something. Yeah.
Oh, I just said absolutely. Sorry.
Yeah. Yes. No, it's good. Okay. So then that ties into accessibility and reimbursement for the therapist. Because if you don't have access to high-speed internet to then do telehealth, individuals that work in rural areas tend to be paid less. That's not going to want to encourage highly skilled clinicians who have a significant amount of student debt to want to go somewhere that's more rural where they're going to be paid less. If we look at ways to overcome, I'll go to that one next. Equity. When I think about equity in treatment, the first thought that comes to mind is insurance paying for the products that the patients need, right? And that looks like a stretch on the surface, but hang with me. I find that typically my families that are not as educated with health literacy are the first to get dumped on sugar-based products, right? So they're not the patients that are coming to me that know about Nourish, that know about Cake Farms organic products, right? They're getting pumped full of the sugars that are high sugar because, that's something that's readily available at the pediatrician's office. The pediatricians themselves probably don't know about it. And so now I have a kid that is G-tube fed or maybe exclusively oral feeding, but they're basically drinking the equivalent of 5 frappuccinos a day and sugar crashing in between, have constipations, and now we're gaining weight. So our BMI looks good, but not really, because if we do a complete metabolic panel, their iron's in the toilet, their protein doesn't really look that good, but hey, they've put weight on them, right? So when I think of equity, my next thought is, are these patients' caregivers aware that Medicaid will pay for these higher quality products? And has anybody taken the time to ask them? Megan, your eyebrows are like, yes. Yes. But that puts it on us as therapists to advocate for that. If I then go over to inclusion, I think back to what Lindsay was saying at the beginning when she was describing the different arenas with which we practice, like not just as therapists, but also as advocates within the scholarly academic realm. So if we take it from the beginning, and hang with me, I think the beginning is where we're taught and where we're learned. If you are actually teaching the pediatric feeding disorder class, or if you're the dysphagia professor and you're charged with teaching the couple nights on PFD, what case studies are you pulling? Do you have DEIA representation in your syllabus, in your case studies? Are you pulling in chest feeding versus breastfeeding? Are you pulling in the patient has thickened liquids and they're on pureed foods, but by the way, they're also kosher? Are we systematically exposing the next generation from the beginning to these variables? Are you creating a case study where they live rural and they don't have access to health literacy and knowledge, and maybe they have a 3rd grade literacy level themselves? But where is our inclusion of these case studies in our research? If we then go to, we're teaching them, but what are we teaching them? That pulls in the research aspect. Are we looking at DEIA from a research perspective for PFD? Are we actually doing studies on rice versus applesauce for modified barium swallow studies? Like, are we actually considering these variables? Because I had one mom tell me through the interpreter one time, she was like, we don't eat applesauce. That's like rotted food. And I was like, honestly, it kind of looks like it. So I get it, right? Like, that's, if you didn't grow up with it, I understand. Also, I like grits, but cream of wheat, that should not be a food, in my opinion, right? Cultural difference. That is not, also green Jell-O, not going to do it. Just not happening. But are we including these factors in our research? And then, by the way, when we're treating and working with these kids, we're talking about school-based cases, right? Feeding doesn't stop when the kid turns 3 and goes to the public schools. Kristen West says it follows them in like a backpack. It does. It follows them in like a backpack. But we have resources about how to do this in the public school that honors their faith, their cultural traditions. Dr. Goza led the charge 2 years ago with the giant journal in the language of speech, hearing science in the public schools, where we went through from screening all the way to the end on how to do this and how to do this well. And if memory serves correct, it was Inéz Villanova. I think it was Inéz that wrote, she was first author on the journal on how to consider cultural practices, right? So we have access to that for free. As a licensed member, as a licensed certified member through ASHA, we can pull all of this. The research has been done. So to go back to what Inéz said, she gave up reading she said she gave up reading fun books. That's the equivalent of me reading trashy vampire novels that have romance. And they do not glitter to death. They're going to burst into flames because any self-respecting vampire does that. But I gave up reading some of those to deep dive into journals because that's what we've been called to do. So if we wrap it all up, because I am angry and we're working through the anger, what resources can we go to? Dysphagia Outreach Project, people. advocate for your patient. If they don't have access to bottle nipples, to formulas, and you're trying to fight the good fight, reach out to DOP, fill out the paperwork. It's a pain in the ass. I will give you that. It is a 5 to 10 page document that will take time, for which you will not be reimbursed. But we can step it up together and advocate for that. We can reach out to Feeding Matters because they have a scholarship that can help families that are getting belittled and enduring medical gaslighting to get a for free second opinion, because, oh, by the way, they give them $2,000 to $4,000 in a scholarship to get where they need to get for a second opinion. You can go to findhelp.org. This year's PFD co-chair, Juliet Ochura from Boston Children's, she told me about findhelp.org. Put your zip code in, and anything your families need or you or yourself need, you'll find there. And on that note, not all of us work in unicorns like Boston Children's. They have quick access to resources, the likes of which I couldn't even fathom for Shenandoah Valley, much less if we cross the mountain and go over into Page. It's the equivalent of hightailing it from Columbia, South Carolina down to Red Bank, South Carolina. You ain't going to find nothing out in Red Bank except maybe a pothole, and I did get chased by chickens. But if you don't have access to care, there are these resources there. And then volunteer with Dysphagia Research Society, National Foundation of Swallowing Disorders, Feeding Matters, and reach out to the ASH Foundation. And if you want to do the research, those are the resources that you can apply for funding to help with your scholarships to put equitable research in place when we're watching it get slashed down at a federal level. Okay, that's what I got. I'm going to drink tea. Thoughts?
I pulled when you were talking about the case studies, and are we doing, when we do our lectures, are we pulling in case studies from, or developing a study or whatever that focuses on those elements? And I kind of wanted to bring up something that Megan said the other day about having, like, instead of, let's say, having one of us guest lecture and talk about our professional experiences, she mentioned having families come in and talk about their experiences, whether they were good, they were bad, what they wish the clinician or the hospital would have done differently for them, or, you know, what were the good things that came of that. So, Megan, I don't know if you wanted to talk more about it, but that's what came to mind when Michelle was talking just now.
Yeah, I think what you and Michelle said, Lindsay, like thinking about just being very innovative. When Michelle started talking about, of course, you know, other countries, what their service delivery models are, thinking about like telehealth and access to care. A lot of that goes back to innovation, like how we structure our classes in regards to, are we focusing on trained experience, what you go to the clinic and what a clinical instructor, you know, may teach you systematically about how to actually do a treatment session or work with the family, versus lived experience. And that lived experience oftentimes is going to come from that family. But it makes us think about, how do I make this learning experience novel and different so that I am trying to make sure we're training, like, you know, this new generation of clinicians that are thinking very innovatively. It's not just like, how can you critically think about this information that's in this article, but how can you be innovative to actually, you know, incorporate your knowledge of these different cultures or the different service delivery models and practices. So a big part of that is really trying to kind of, you know, egg everybody on to like think different, think outside of the box. You know, even if we were shifting this conversation to kind of say, I know one of our big questions is like, what does it look like? What does DEIA look like? So like, you know, Inéz said earlier, if we take away this acronym, what does it look like when we start to say, okay, it's not going anywhere? We have to address the big elephant in the room, the challenges that we have, and how are we going to do that? And I think just one of the answers is being innovative. Like, we have to be very innovative. The language we use, our approaches, leveraging our patients and our families' voices as much as possible too.
And we need that 93% also to stand up and shout and support. Like, Meredith has said a couple of times, like, I don't know why I'm here. But Meredith, I was introduced to Meredith a couple of ashes ago through Inéz after we did our first talk. And Inéz spoke, before I even met you, she spoke so highly of you, like your character and the role that you played in supporting her in her journey to where she is right now, and just how sensitive you were to the things that she needed. And that doesn't happen for all of us. So I'm going to thank you for that, because Inéz is remarkable. She's a valuable asset to our field and to our specialty area. And that is valuable, that you are part of that 93%. And you said, you know what, I don't care. I am going to provide Inéz with everything that she needs to be a remarkable clinician. And you have added value to this group of ladies. Your perspective has been so intelligent and wise. And talking to you gives me hope. And talking to Michelle gives me hope, in that we have people who look all different kinds of ways. I don't care if your skin is purple, pink, polka dot, zebra stripes, what your inside is, what your heart is. That's what's important in helping to move this field forward. Okay, so I've been meaning to tell you that, Meredith. You are.
Well, thank you so much.
Oh, yeah.
You made me cry.
Sorry.
I mean, amen, but amen, because I feel like that's a case study within itself to show how, individuals can like walk alongside and say, this is my role. This is the action. I just very well said, Lindsay and Meredith, I agree, but I feel like that's a case study within itself.
Yeah. And Inéz has heard my story about the experiences that I endured during my doctoral program and how I was made to feel. And I'm going to try not to cry, but I just wish that I had a mentor, a supporter who viewed me as someone who needed that uplifting, who needed that extra guidance and support, and that I wasn't a burden or, I was just kind of there to fulfill whatever quota may have needed to be fulfilled to add to diversity. I needed that. And to see that someone that I truly enjoy talking to and working with, Inéz, knowing that she has you, allows me to say, okay, in 10, 20 years, Inéz is going to be amazing. And you have contributed to that. And I think you're amazing too.
Thank you.
Yes.
You are too.
Thank you.
You guys all are. Seriously, just the smartest group of women I've ever met. I always have so much fun with y'all when we get together and talk, and I always learn so incredibly much from you guys, both personally and professionally. It just never stops to amaze me what happens when we get together.
It's kindness matters. There's a thing here in Stanton. It's like the town motto, kindness matters. And that to me is how collectively we will overcome the world burning, is by choosing to be kind, choosing to be humble. And I mean, my Jesus washed everybody's feet. And so that's, I don't know if I could, because I don't like feet, but I'm there with the theory. But all right, now Leena, I'm going to throw you, Johnny, on the spot, because you are our future. Give us hope. Give us hope. Close us out with some peaceful, encouraging thought there.
Yeah, it was beautiful to hear what you guys were talking about. I think I have been so privileged in having amazing support with you all, with my program. But one thing I want to emphasize to all the students and the new clinicians is to be proactive and advocate for yourself. Nothing will be handed to you. You need to go out and ask for what you want. And especially when it comes to pediatric feeding and this niche specialty that is very hard to get into. There are a lot of barriers for individuals from minority backgrounds to get into speech pathology in the first place, but getting into pediatric feeding is much more difficult. But I think there is support out there. It might not be right in your area, might not be in your program, in your clinic or place of work, but there is support. I think advocating for yourself and advocating for your clients is kind of the theme of what we talk about. DEIA, I believe, stems from kindness, open-heartedness, and advocacy for others to provide equitable outcomes. But that doesn't only apply to our clients and patients. It applies to ourselves as professionals, as students, as new grads, as whatever you are. I just think advocating for yourself and seeking out support is what I'd love to tell everyone.
Michelle, thank you so much for kind of opening this up. I remember our first conversation because I missed that big committee meeting, and you and I had a little one-on-one, and we talked about this a little bit, and you told me about Inéz, and I'd be remiss if I said that I was super comfortable with the topic at first. I was like, is she asking me because I'm Black? So I don't know, I get so entrenched in what I do that you allowed me to kind of open my mind to some different variables and different factors that affect us as speech pathologists that, of course, I already knew about, but you just made the space very safe. And because of that, in 2023, I was able to meet Inéz, and then last year, these ladies. And then now you're giving us this platform to talk about something that I believe we're all passionate about. So thank you so much. And thank you for the work that I know that you're going to continue to do for our field, for our specialty area, for the clients that you serve, and all that will help us to keep pushing forward with confidence. So thank you.
Oh, sometimes I think being a speech therapist, everybody's like, oh yeah, I'm going to grow up and teach tiny humans to talk. And I'm like, good luck with that. Because if you wake up with, I had a patient tell me one time, girl, get your IRA up. And I was like, what's an IRA? And I had a whole lesson on hot mad and what it means to be hot mad, but then to turn it into advocacy. And that's not something that we do enough for teaching the next generation and mentoring the colleagues. And if we need advocacy on so very many, many, many fronts, but it's the safe space. Yes, you're going to be uncomfortable, but we can be comfortable in the uncomfortable if we're surrounded by kindness that truly wants to improve. And that's what this is about. And address the elephant in the room. Pop it. Let's move on about our business. I got shit to do at the end of the day. Pardon my French. I'm hoping some lovely human will edit that out, but I have things that I need to do. And it is the next meeting is calling. We are better together. And that's so everybody, if you're listening, it's Pediatric Feeding Disorder and ARFID Awareness Month. And we want to thank you for joining us to kick it off with a huge amount of advocacy, as well as hope. There is always hope. We're 300 and some odd episodes in, and I'm hoping that you take away the hope. So we will get up tomorrow and we will do this again, and our patients will be better for it and our profession will be better for it because we're choosing kindness and we're choosing unity over those that want to tear it down. So ladies, thank you for being brave and joining us. If you were here, I would have poured you all a cup. Also, my tea fortune of the day, because this is important, it said the principal ingredient of life is love. And I think that's perfect. it's always an adventure. Like, what am I going to get from my tea fortune? And I'm not talking about like reading the tea leaves. I have a sister-in-law that can do that, but I wait for that one. So, folks, in the show notes, we'll have everybody's favorite scholarship or donation. So if you got a little bit of mad money lying around, feel free to donate it to there, and I'll make sure to put it in the show notes that get put on the Apple Podcast app and the Spotify. I'm sure it's other places, but I am not that cool. So everybody, thank you. Thank you for having me.